So I was going to take you through a kind of whirlwind tour of what our Best of DDW program through Cornerstones, where we, out of 1,000 abstracts that are presented at DDW, we whittle it down to 100, and then I sub-selected a group that I thought would be most clinically relevant to today's meeting to really take you from the podium to your practice today. As Gil has noted, you're going to start small, and I'm going to kind of give you some new data that's out there that may help change your practice tomorrow. So we're going to walk through a little bit some of the key areas, but overall our Best of DDW highlights many different areas of the space of IBD. And so we're going to focus on, again, those that I think are going to change your practice. So if we first focus on diagnosis, prognosis, and prevention, I'm going to kind of tease you in all of these different areas because there was like highlights that I think would be of interest and some cool things and things that are clinically relevant. So this one paper looked at the fact that some of us find terminal active ileitis, meaning you look in or there's mild active ileitis without chronic changes under the microscope, and people want to know, what does this mean? Is this Crohn's disease? Should I be treating them for Crohn's disease? I think we've all had patients who came to us with a diagnosis of Crohn's disease based on active ileitis without chronic changes, some of them even on biologics. At least I've had patients who I have to say they don't have Crohn's disease. So a lot of people are nodding that they've had this experience. Well, the one thing that was interesting is that the people who ended up having true Crohn's disease over time was a very small proportion of people who present with this finding, that only approximately 5.5% of individuals ended up with actual diagnosed with Crohn's disease. And the progression to Crohn's disease was more so seen in individuals who also had unintentional weight loss. When you go back and you see that weight loss was a part of their presentation as part of the indication for actually undergoing the colonoscopy, that tended to be associated more so with those who developed Crohn's over time. But just a note that the majority of people do not develop Crohn's. So the importance of you undiagnosing Crohn's disease in patients with acute or just active ileitis is something that was studied by this group. Then there was another publication or poster presented on a screening tool for dysplasia in IBD patients, specifically for colon cancer and high-grade dysplasia, which I think is important because those of us who are screening IBD patients for colon cancer, and whatever the screening frequency, whether it's 1 year, 2 year, 3 year, or in the UK suggesting maybe 5 year, it's being pushed out more and more as our therapies are getting better, so that if you had 2 normal scopes, for example, you can then push out the frequency of how often you want to check for dysplasia. What this was a stool marker, stool DNA, that actually had an area under the curve of 0.93 for colon cancer and high-grade dysplasia, meaning it was accurate in detecting those two with 93 or almost close to 100% accuracy, and there was only 7% or so false positive rate. So the idea that maybe there was a tool that could help us in between the colonoscopies have patients actually be able to be screened for high-grade and low-grade high-grade and dysplasia and cancer. Interesting, low-grade dysplasia was only 0.71. So the idea is that aren't we supposed to be preventing high-grade and colorectal cancer? So the idea is, okay, it's really good at telling you that you should look in now. There's something that's brewing. But in a low-grade dysplasia, that's where we wanted the most ability to actually have accuracy. So it fell short on the accuracy for low-grade dysplasia. Let's talk to disease-related outcomes and natural history. So Dave Binion, Ray showed about his CRP paper where individuals who, by way of a IBD-Q, meaning the simplified IBD quality of life questionnaire, said, I feel fabulous, but their CRP was elevated, and they followed those patients over time, and CRP was a marker of bad outcome, meaning went to surgery or had a complication. He has this very nice prospective cohort that he follows, and he went back to this cohort and he actually saw that monocytes, which I don't think anyone in the room has ever thought to even look at as a marker of poor prognosis, but what he actually said, and monocytes are macrophages and dendritic cells, which are antigen-presenting cells in the immune system that actually are interacting somewhat closely to the initial trigger of bacteria in the gut lumen. He looked at monocytes, and what he showed is that if you look at surgeries or hospitalizations, the odds ratio are quite strong in individuals with ulcerative colitis who have monocytosis. And I'd say that's where more it was of interest in terms of outcome measures. In Crohn's disease, there was a 2.5-fold increased risk of surgery and hospitalization. So the idea is that these monocytes were markers of bad outcome independent of CRP, which I bring to the attention. So maybe he'll be now looking at monocytosis as predictors of outcome. I don't know, maybe tomorrow you'll start looking at your differential and see whether monocytes are actually, or on Monday, monocytes are actually part of changing in your management strategy. But I thought this was interesting that this was a possible new marker that predicts severe outcome worthy of investigation. One of my favorite abstracts was actually in a presentation that looked at the visceral adiposity on CT scan. And we know that fat harbors a lot of TNF and inflammation. And so the idea is that despite having maybe a risk factor or factors that impact phenotype, meaning surgery or complications such as smoking or duration of disease, what they found is on their cross-sectionals of their CT scan, the amount of visceral adiposity that was found at the time of a CT was more so predictive of bad outcome. And I think we can all know that we're having increasing evidence of bad small bowel Crohn's disease despite even patients who meet the criteria of obesity. So we are definitely seeing the fact that fat may be a harbor of TNF and may actually impact not only the way people clear drug, but may actually impact their prognosis. So I thought this was really an interesting talk on, or discussion point on the role of visceral adiposity, particularly for patients who ended up having surgeries and penetrating Crohn's disease. So it's interesting to think about that. We never really thought about the role of adiposity or adipose tissue. On the other end is malnutrition. Now, I think one of why I wanted to highlight this as a clinical practice point is that malnutrition is up to 30% of patients with Crohn's disease in particular, but IBD have malnutrition. It is probably one of the most underestimated elements of when a patient comes in, and underappreciate the fact that the majority of your patients who are coming in with flares often are losing weight because they're adjusting their diet. So the number one reason for malnutrition was food avoidance during flares with an odds ratio of close to 10. So your patients are under the impression also, we all know, that certain foods increase the risk of IBD, and that 80% of patients avoided foods during flares with the hypothesis that it worsens their flare. You all know that. They've stopped lactose, or they've stopped gluten, or they're eating potato starch, whatever is the next big thing on the web, can't keep up. But the idea is that there is some nutritional element that is contributing to malnutrition. I think we are underestimating its presence in IBD, so I'd love it if people could start thinking about assessing nutritional status, especially patients on corticosteroids. You know, they get sarcopenia, they get really, really thin limbs, but they have a lot of fat here and here. But if you look at their legs and their arms, they've got a lot of lean body mass, or they've lost a lot of their muscle mass. Okay, moving on to the therapeutics. You've seen from the various talks some of an update. Everyone kind of got the DDW slides updated, but I'll just remind you of the Tofacitinib data. That was the phase 3 induction. We should know the maintenance data very shortly for the two induction trials. And just as a reminder, the induction remission rates on the dose of 10 milligrams BID, which would be the induction dose, was similar. And the only difference between the two trials was also the fact that the placebo rate was quite low in this trial. I want you to pay attention to these placebo rates, because these are actually, especially 3.6, is very low as it relates to placebo in IBD trials. And I'm going to show you something very interesting in a moment. But just keep in mind that one of the things that was highlighted is that even if a patient was One, it doesn't need therapeutic drug monitoring, or so we don't think so at the moment, but that the efficacy was similar in naive to exposed. So that's often the dialogue we keep talking about is, are these new therapies going to be effective in patients who failed everything, for example? And when you switch out of class, does the idea that they've been refractory and exposed to TNF, is that going to impact the ability of these drugs to work? So one of the highlights was that it didn't matter as compared to what we saw with some of the Utilization data, where it did matter if exposure to TNF had occurred. The idea is that it does not look with TOFA that TNF exposure impacts the outcome. In terms of the Crohn's data, a reason why I want you to pay attention is look at the placebo rate in the phase 2. So the placebo rate was 3.6 in a phase 3 UC trial, and here we have a placebo rate in the 30s, almost 40% in the Crohn's phase 2 trial. So it's important to remember, one of the things also for this Crohn's trial is that although endoscopy was needed to get in, they didn't need a minimal endoscopic score of 7, for example, which is what all the Crohn's trials are going to need. So truthfully, when you pull out those patients who actually had met the criteria that every Crohn's trial would meet in the current era of designing Crohn's trials for endoscopic assessment, when you take those patients who had an SCSCD of at least or 6 or above or 7, the trial was positive. So it's important to remember when you look at trials, you need to be aware of what are the details of the kind of patients that go into trials when you interpret. Granted, it's dead for Crohn's disease, it's not moving forward, but I want you to know that there is important to always review the way studies are designed, especially phase 2 trials. Speaking of phase 2 trial, the Fitzroy study showing again that JAK1, just a reminder because I'm sure it was discussed, that TOFA is JAK1/3, filgotinib is JAK1 only. In terms of speaking of the selectivity of that pathway, showing you that using old school CDAI, which is kind of like not new school, but old school CDAI, and you notice here that the endo data has not yet been presented, but will be at some point. We'll be able to see whether this therapy similarly, if in the CD space, has endoscopic change, but at least for now, the p-values for their subjective or clinical parameters hit. This was interesting. This is an endoscopically administered at the time of colonoscopy at week 0 and 4 weeks, administered a TLR9 agonist, meaning upregulate, meaning not antagonist, not blocking, where it was sprayed at the time of the colonoscopy twice at 0 and 4 weeks. And what's interesting about TLR9 is from an immunologic perspective, it actually has a lot of impact on the antigen-presenting cell and the macrophages, monocytes, I suppose, too, and that what was impressive, I thought about this, not insignificantly small, 131 patients, but what was impressive is that the data looks quite impressive at the moment. So we'll follow this closely to see for UC patients whether endoscopically administered agonists as opposed to blocking with monoclonal antagonists, for example, actually, or maybe in combination. So we'll see and wait to see what the next phase is of this study, but week 12 remission rates were quite nice. The FMT story, interestingly, there was the study where a patient got FMT through colonoscopy at the first one, and then 5 days a week, for 5 times a week, got an enema for 8 weeks. So I'm sure you always wonder what kind of patient would sign up for that kind of trial. But anyways, Dave told me yesterday that they made the placebo smell like the actual stool, so you couldn't tell, because that would have been a giveaway, I guess. I didn't even think about that. I'm not sure what they put in the placebo to make it smell like stool, but that's interesting. So endoscopically, it really wasn't changing the endoscopic appearance, but it met some clinical endpoints. It wasn't steroid sparing, but they met their somewhat clinical endpoints. So we'll see again. I think, as we know, fecal microbial therapy will be evolved to, we know we're moving to capsules, but also more targeted. So for example, it's not going to just be everybody's stool, all bacteria. I think we'll be targeting and creating a pill, for example, that has 17 Clostridia species, or moving towards more customized microbial therapy. The anti-IBD diet, which was coined here from a colleague here in Chicago, which is essentially the SCD diet in a sense that you're restricting carbs, wheat, most grains, additives, and preservatives, so emulsifiers. And she actually randomized patients, which is a feat in itself, to take basically sugar or fructooligosaccharide, which is FOS, not full of shit, placebo, and I just realized, and then the anti-IBD diet, and showing you here the difference in the outcomes. So as we see it translating into some basic or translational science and see what this is doing to the microbiome, which will be really, really interesting, just to show you that there's people interested in the role of diet, obviously, but we're very interested in the role of the microbiome and what it does and how sustainable it is. So let's move away from small molecules or diets into the biologic space. Dave or somebody showed you the STORI trial, maybe not, that the STORI trial, I think the final chapter has been written. If the STORI trial, just as a reminder, were patients who were on durable combination therapy of infliximab plus thiopurine classically, the infliximab was removed, and actually they were just kept back on the thiopurine for which they were failing before, for which TNF was added. We wanted to see whether or not once you put someone into what is considered to be a clinical durable remission for at least 6 months, remove the therapy, how long could people stay off the TNF therapy? And what we kept seeing increments of every year, kind of seeing what happens over time, and we went from X percentage to X percentage, and this is what we now know, that the cumulative incidence of needing back on a biologic was almost 80%. So 2 out of 10 patients at the last 7 years of the STORI, 2 out of 10 patients stayed off drug, but the majority needed to go back on something. Now, originally in the first STORI iteration, which was the gastro paper, everybody who was reintroduced was able to be reintroduced successfully. Now we know that 2/3 were reintroduced successfully and 1/3 did not successfully get reintroduced back onto infliximab, and the median time from stopping drug to reintroduction was 13 months. So just around a year, people were able to stay off before reintroduction. But 50% were less and 50% were more, because it was a mean, drug holiday, anywhere from 6 months to almost 3 years off. And so again, the emphasis is the fact that even though we're trying it, and what's interesting is that despite this, they have the SPARE trial, which is a study done in Europe where they're actually de-escalating, for cost reasons granted, anti-TNF therapy, and using some biomarkers to determine who may need to go back on drug and not waiting for people to flare. Anyways, that's going to take a while, so we'll see how that all flies out. But interestingly, this is now the STORI 2 would be in ulcerative colitis. That was Crohn's disease. This is UC. Similarly, over time, most people need to go back on anti-TNF therapy. And what's interesting, but not shocking to anyone in the room, that if someone transitioned from infliximab to be maintained with 5-ASA, so you're going from literally taking someone who needed anti-TNF to maintain them with 5-ASAs, those flared the fastest. No one in the room is shocked about that, right? So it's almost laughable. So the idea is that, if you're going to use something that you're going to maintain them in maintenance off of, you're going to probably want something that has a little durability and actually has some anti-inflammatory, immunomodulatory effect if they failed 5-ASAs to needing to go on the TNF. Anyway, so this again, but what was different is that they actually had 17% of their patients had infusion reactions, which is more than what was reported in the European group, and only it was a 50-50 chance of being successful, which is what I think around the room in the appropriate panel, I felt everyone was like, it's 50-50 whether you're going to be successfully reintroduced. So this kind of fits more with what we're seeing in the real world experience and what people thought when we did the panel. On the biosimilar story, this was the purpose of this presentation by Fiorino, was to just say that if you took a patient who was on the innovator or the originator, so we'll say infliximab, and then transition to the biosimilar infliximab, they did as well as someone who was naive to the biosimilar infliximab, or who had seen infliximab in the past, or adalimumab, but the majority was the majority was adalimumab, and then switched to biosimilar infliximab. They all did the same. The point of the study was to say is that biosimilars are going to come to us as they've come to Europe, for example, especially Hungary. Peter Lakatos has really been a leader in this in the Europeans. But to say that it didn't matter how your patient was switched or not to a biosimilar, they did the same. And that was the point, is that your patients may be transitioned off of Infliximab onto a biosimilar starting in 2018, and you may or may not know it. And so the point is that they look to do okay. Whether or not this evolves to say that there will be immunogenicity differences, as of now, there's no data to support that when you transition from one anti-TNF to switch them even within the biosimilar space, that immunogenicity is different. Let's wait to see how that evolves in our hands. The ustekinumab maintenance data, this is just to show you that for some reason the value keeps coming up as a problem on the slide, so I apologize. This was just showing you that if we prepare possibly for September 23rd approval for ustekinumab, this is the maintenance data, that 90 milligrams Q8 worked better than 90 milligrams Q12, which will probably be the approval dose that will be coming out after, we hope, an induction of 6 milligrams per kilogram, one-time IV, and then follow into the sub-Q pattern. The safety, no malignancy in the 90 milligram QA, and there was a 0.8% in the Q8, similar to the malignancy rate in placebo. You can see the serious infection rates is the reason why it's lower in Q8. Why? It's because there's less perianal abscesses and less Crohn's-related adverse events when you give better drug and more of it. So that's why the Q8 appears to be better than Q12. The selective IL-12 blockade with risankizumab, which what I loved about this being at DDW is this, that we finally have in an actual trial mandated endoscopic outcome as part of what we see for this drug. You would all know that CDAI had been for every other drug that you've ever seen presented to you, right? That has not, endoscopy at 12 weeks has not been the outcome. So just the idea that we have, and look what happens at a placebo rate when you're just asking someone how they feel compared to when you're looking. Please pay close attention that objectifying your outcome, which is what Ray was getting to, will help you use drugs better and help patients get better, really. Not just subjectively, but really. Last section, anti-TNF does not increase the risk of cancer. There was a meta-analysis to confirm one of the questions that had been asked before, but this was two meta-analyses that were presented at DDW, telling us again, confirming that there was no increased risk of malignancy recurrence in the face of TNF. The pediatric I already talked to you about, but this is the 23,000 patient years of follow-up and a 2.7-fold increased risk of malignancy in children that were exposed to thiopurines. This is the standardized incidence rate comparison, so looking at the SEER database, and if you look here, thiopurines plus or minus a biologic versus non-thiopurine exposure, 2.7 for standardized incidence rate. So this is just, this is continuing for 20 years per the FDA, so we will continue to follow these kids over time, but already 19 cases of lymphoproliferative disease. So we're moving, as I noted in the discussion, away. Speaking of checklists and quality, it appears that vaccinations are not being given to our patients, and like Gil said, if you rely on trying to remember next time to remind the patient, so a checklist is one, but also having part of your team to also be responsible for ensuring, so when your pharmacist is calling to make sure that your patient's drug levels are being monitored, or you're also going to make sure, right, that they actually have gotten their vaccination. So it's all about that health maintenance, tight control piece, and a nurse, obviously, or any provider who's interested in helping us optimize the care. Does drug levels, Dave already showed you the Entyvio exposure, so this was taken from our best of DDW, also showing you that high CRP, getting back to my discussion of that, clearance is very important when it ties to any of these therapies. As a reminder that low albumin, high CRP, high BMI, bad, drug level probably low, increased rate of antibody, need to optimize and keep a close eye on your patients. The group from who originally gave us a paper last year that you could use 3 doses of Infliximab within 24 days rather than using it over 42 days, who showed that their 90-day colectomy rate was less when you did accelerated dosing. Actually turned out that over time, their colectomy rate didn't change. If you look further out, it was just in the short term. This is just showing you where they used a concept of having high CRP albumin. So they looked at a CRP albumin ratio, and they actually showed that if in the hospital your patient's CRP was high and your albumin was low, those patients had the highest risk of colectomy. So if your patient's ratio is greater than 1.75, please optimize your dosing of whatever drug you're on, because those patients will probably lose the drug in the stool. Goes back to my presentation on pharmacokinetics. This, as I mentioned before, perianal disease. You can see that fistula healing really started to jump once you got levels greater than 10, and even started to jump a little bit when you had levels greater than 20, it's supposed to be 20 to 25. So the idea for perianal disease, just don't stop at the standard 5 to 10. Please push your dosing if you can, based on the payer, of course, the limitations. Lastly, placental transfer of biologics to infants was not associated with increased risk of infections. What I do want to point out here is we had a ratio between infant serum level and mom level, and I do want to point out that the ratio was highest in babies who were exposed to Infliximab in utero. Second was adalimumab, which was similar to ustekinumab, and then you could see small numbers, but you can see vedolizumab, Cimzia, certolizumab, no drug in baby, and this shows you the exposure. So remind you, it doesn't mean we stop drug, it doesn't mean we do anything, we don't switch to things that cross less. All we do is follow. That's all we do. Just letting you know that, yes, we know the drug crosses, but again, we haven't had worse outcomes. In vitro fertilization, Sonia Friedman and Adam Schafis first told us that IVF is no problem, same as the general population in IBD patients. What I do want you to be aware of is that the in vitro or assisted reproductive technology, there are some issues with not, in the end, when they looked at a more uniform database up in the Netherlands, they actually showed that it's not true that assisted reproductive technology is not across the board for all IBD patients, the same as non-IBD patients. And thankfully, the patients who did the best are the ones that need it the most, which is post-J-pouch. In women who have undergone colectomy with pelvic dissection and who have either had a proctectomy or a J-pouch, the risk of infertility increases 2 to 3-fold, so it's approximately 40 to 50% infertility rate due to adhesions that form around the fallopian tubes and the ovaries, so it's a plumbing-related issue. And therefore, assisted reproductive technology is often needed, and the good news is that that's the group that actually does the best, so it made me happy that that was actually where we use it, and in my preconception clinic, that's what I constantly refer back to, these women who are going to need increased infertility. Little update on environmental risk factors, because everyone's still obsessed and wants to know, did I eat something? Did I get exposed to something? If I live on a farm, is that good? So this is just different summary of all the environmental stuff that was presented to DDW, that patients who indicated that milk consumption, that if you drink a lot of milk, you had decreased risk of Crohn's. So you can tell your patients who blame it on milk, important, blame it on lactose, whatever they're blaming it on. In meta-analysis of 29 studies, that if you're exposed to farm animals or surrounded by pets, you're actually protective against the development of IBD. So if maybe there's one sibling who already has it, get a lot of dogs. Maybe the future siblings, surround them with either pigs or farm animals or something, maybe that'll decrease. And then just to summarize, the H. pylori, interesting, was protective against IBD. So anyways, so best of DDW summary, we found there were novel predictors of complications such as monocytes. The JAKs are here, as Russ alluded to, here to stay, and the next generation and generation thereafter of the JAKs I think are really exciting. Ustekinumab, we finally saw maintenance, will be in your hands in the fall, we hope. And also the next generation of that with the IL-23 selective, which is even more phenomenal, I think, in terms of its selectivity for IBD is next. Biosimilars really are similar. Malignancy in children associated with thiopurine exposure. High CRP, low albumin, important for biologics. Placental transfer of biologics are there, but not associated with infections. And point of care testing, which there will be there's a lot of exploration about looking at calprotectin through the phone and looking at drug levels and being able to detect it through a flow assay at the time of the infusion. So people are exploring how we can improve point-of-care testing to get things done faster to get your patients into remission. So sorry for going over time, but I thought I had more than 5 points, obviously. But thank you for your attention.